Hey, it's Dr. Bill with just the tip of urology school. Welcome back. We're going to tackle interstitial cystitis. Again, my appreciation to the AUA and the core curriculum, which nicely outlines a somewhat confusing and perplexing topic, interstitial cystitis. We find that a lot of people who present themselves to urology with a diagnosis of interstitial cystitis actually don't have it. Look at the table outlined in this chapter, and there's a pretty significant differential diagnosis. In general, we want to identify people who've had bladder discomfort or discomfort perceived to be in the lower abdomen, associated with a variety of different kinds of lower urinary tract complaints for greater than 6 weeks. That is not associated with a urinary tract infection or other types of pathology that can cause significant frequency and irritative complaints being categorized as LUTS or lower urinary tract symptoms. So a lot of people will come to our clinic with this diagnosis, but really have not had a full urologic evaluation, and most have not had a cystoscopic evaluation. So often cystoscopy and the possibility of a bladder biopsy is required to rule out the other diagnoses listed on the listed in the chapter. And the most significant diagnosis that could be missed is a type of bladder cancer, carcinoma in situ. Remember that both men and women can suffer from this pathology, and that though men are at about 1% of the number of people diagnosed, where females are the vast preponderance of people who are diagnosed with that malady. It really requires patient buy-in because there are a lot of behavioral psychosocial changes that need to be addressed, and something as simple as diet, which can be burdensome for some of these patients. A lot of them come in with depression and anxiety and anger because they haven't been believed before by their other practitioners. They feel frustrated, and they feel a total loss of control. Why is this happening to me? I'm too young, I'm too old, I'm too happy, I'm too whatever to be suffering with this. And so we try to give them back their control by letting them know that once we've identified or ruled out dangerous pathology, then we look at ways of controlling their complaints. And the big issue is diet. Well, I love my wine, or I love my tomatoes, or I love my particular sauce or foods or coffee or alcohol, whatever it's going to be. It's okay to have it. It's not dangerous to have discomfort or pain or that very vague, weird sensation of something not being right. It's in your control. If you don't want it, if you don't want to experience those abnormalities, then limit or eliminate the offending factors. And you'll see that in the chapter, there are some rescue treatments that can be employed to soften the blow of dietary indiscretions. I like alkalization of the urine, a little bit of baking soda and water, which is really a home remedy. People use that for heartburn or GI reflux. And it does the same thing in the bladder. It alkalizes the urine in the bladder, bathing the bladder, and softens that discomfort that often occurs with dietary indiscretions. Remember, interstitial cystitis is essentially a breakdown of protective layers in the lining of the bladder. And so when there are certain things, potassium-rich foods, acidic foods that are utilized, it passes through that protective barrier and causes some discomfort. Also understand that there's a long history of the use of Elmeron, which is a way of recoating the bladder. That's recently, over the last several years, been associated with some macular pathology. So it's always good to have a good relationship with ophthalmology, having your patients go to someone who understands the potential side effects of these medications to rule out significant macular problems. This is one of those complaints that a lot of patients like to put their 2 cents in, and so there are a lot of blogs, patient resources that are out there. Some of them are listed in the AUA, and also some of the patients who come to you have had a long history of running to different doctors, different urologists, looking for that particular clinic that has a sensitivity to the complaints that people with IC have. Read the core curriculum on this, but remember that there's a lot to be learned from by patients who've had a long history. What has worked from them? What do they like? What do they don't like? We also have a number of people in our clinic that have an interest in IC and have had good, strong, long-standing results with their patients. Confer with them, and make this a lesson of the various etiologies to one particular problem, utilizing medication, behavior modification, psychosocial support, and using physical therapists and therapists as well. The other issue is that a lot of people, and this should really be remembered, that a lot of people use Kegel exercises as a panacea for all, quote, bladder, unquote, problems. I don't know if that's the best way to go. In fact, there's some data that indicates that Kegel exercises can worsen the situation. Don't think of strengthening or increasing muscle tone, but utilizing some basic floor yoga exercises to relax the pelvic musculature. A little bit of a lot of things usually help. So keep an open mind when you're tackling IC. Dr. Bill, with just the tip of urology school.